Okay, so this week's lesson is going to be, our lecture is going to be over IV therapy complications. First complications that we're going to talk about is infiltration versus extravasation. And if you guys recall the first week of class, I think I showed you a picture of what extravasation looks like. And by definition, infiltration is leaking of a non-vesicant fluid into the tissue versus extravasation, which is leaking of a vesicant fluid into the tissue. Infiltration is caused by the dislodge of a needle that has penetrated the vessel wall. Signs and symptoms of infiltration: you'll see swelling, pallor, coldness, pain at the infusion site, and you may also see a significant decrease in the flow rate. If your IV fluids are infusing, your rate may decrease on you, or if you have a pump going, it would start to beep because the flow can't go in at the rate that it actually should go in at. It is extremely important that you recognize any complication. Failure to recognize infiltration could mean damage to the tissues. It could prevent your patient from receiving the medications that they need, and it could also limit veins available for future therapy. So if it progresses long enough, then it would spread in the tissue, which would prevent access to the vein later on, or more of the vein later on. If you have a question, the best way, or one of the best ways to compare or determine if you have infiltration, is to compare extremities. If you have an IV in the left hand and you're concerned that it's infiltrated, look at the right hand. And if it looks a little bit puffier, different color, then you probably have infiltration occurring. So that's a really good way to do that. Make sure that you check for blood. Okay, blood return is also extremely important that we check for. If it's infiltrated, you may or may not have blood return, but we always want to look at it. It's not always reliable because the cannula could still be partially in the vessel. So even though it has infiltrated, you may still get blood return, but it is something that we want to check nonetheless. Nursing considerations and monitoring. What are we going to do? We need to check the infusion site every hour. We need to DC the infusion. If we see these symptoms occurring, we would restart at a different site, so we may have to start an IV at a different place. Limit the movement of the extremity with the IV, and always follow your policy and procedure for monitoring whatever facility that you work at. And if you monitor it closely and as per policy, as you should, then it will minimize your complications with infiltration occurring. Extravasation is when infiltration has progressed to necrosis, and that's due to the irritating or the vesicant fluid that is in the tissue. In order to treat extravasation, we may give an antidote. So I want you to think about this. If I have an IV in the left hand and it is infusing, we're going to use dopamine. If I have dopamine, which is a cardiac medication, right, an inotrope drug, hopefully these terms are familiar to you. If it is infusing in my left hand and I suspect that the IV has become dislodged, then I know that there's an antidote for dopamine. So I would go get the antidote and I would put it where? Would I put it through the same IV that just infiltrated? Would I give them a subcutaneous injection? Would I give them an IM injection? Or would I start another IV somewhere else and inject into that IV? So think about what has occurred with the infiltration, and think about what you're trying to do here with this antidote. Pause this for a second and think about what your answer would be, and then turn this back on to see if you have the correct answer. So hopefully you paused this and you thought about it, and what we would hopefully come up with is what we would want to do is we would place that antidote through the same IV that just infiltrated, because we're trying to get that drug into the tissue that has been infiltrated. So we wouldn't want to give them an IM, and we wouldn't want to start another IV, because then it's going to have to work systemically. It's going to have to go all the way through. But we could also give it subcutaneous into the tissue that has been affected. So there's two different things that we could do to fix that. We want to elevate the extremity to minimize any swelling that's occurring. Some doctors will tell you to apply cooling to decrease the blood supply and decrease absorption of the drug into the tissue. Constrict peripheral veins, which decreases blood supply to that area and minimize pain. Some physicians will order heat application. And heat, what does heat do? It opens up and dilates, right? So it will increase blood supply to promote healing. So it's going to depend on the doc as to what they tell you to do, and sometimes you will actually alternate it. You would start out with cold, and then after about 24 hours you would place heat on it. But I want you to understand why you would do cold and why you would do heat. They each have a benefit. Plastic surgery. We use plastic surgery sometimes as the necrosis comes so bad we'd go in and do wound debridement. And I've placed on your PowerPoint examples of medication. This obviously is not all of the medications, but these are some of the common ones that you would see that you really have to pay attention to and watch with extravasation, because it can happen so quickly. Like, I know whenever we used to administer dopamine, if it was in a peripheral line, we were checking blood return every hour on the hour to make sure that it had not infiltrated, because people can lose limbs from extravasation. Okay, hematoma. Hematoma is formed whenever blood, it's from infiltration of blood into the surrounding tissues around the site. It can be caused by incorrect technique or manipulation while you're inserting the IV, and the cannula passes through the distal vein wall. Opening of the flow clamp for the infusion before the tourniquet is removed could also cause this. If your cannula is too large for the vessel that you're inserting it in, so we go back to choosing the correct size for the vein, using the smallest size needle to get the job done. And also pressure of the tourniquet to really fragile skin can cause that. Signs and symptoms that you may see, excuse me, ecchymosis around the site swelling and discomfort. You may not be able to advance your cannula all the way into the vein, and if you have resistance when you flush. Treatment, we would take the catheter out. Apply pressure, light pressure over the site after you remove it. You want to raise their arm up or the extremity up on a pillow, and that will help with venous return. So you want to elevate the extremity. And you could apply ice to prevent any further enlargement of the hematoma, because we know that ice does what? It constricts. So nursing considerations or preventions that we want to look at. We might want to use an indirect method of insertion rather than a direct. A direct method is just like you guys have been doing in lab, where you take the needle, you insert it over the top of the vein and advance it. An indirect method is where you actually insert to the side of the left or right of the vein and then slide into the side of the vein, and that method is supposed to decrease the risk for hematoma. Using vein visualization techniques. You know, they have these new machines now that you can place them over your patient's hand or your arm, and it actually, the ultrasound, the rays that shows up where the veins actually are. You can use a blood pressure cuff for the patient with fragile skin. Use a smaller needle, obviously we've talked about that before, and apply tourniquet just before the insertion with minimal pressure. Okay, a lot of times we start IVs without even using tourniquets to prevent these complications. Phlebitis is another complication. It's just inflammation of the vein. It's caused by trauma from the needle or the catheter, or by chemical trauma from the IV solution itself. Signs and symptoms that you may see would be tenderness, and obviously this is going to be at the site of the IV. It's locally. Redness, warmth, slight edema. You want to DC the infusion immediately. Obviously, if I have something going on in the vessel, I would want to do that. Apply a warm, moist compress to the site, and obviously avoid further use of that vein. With phlebitis, the induration or the hardening of that area, you would feel like a rope-like feeling in the vein whenever your patient has phlebitis. Thrombophlebitis is a blood clot. Signs and symptoms to that would be similar to phlebitis. IV flow may stop if the clot were to obstruct the needle. Nursing considerations: you want to DC your infusion immediately. We would apply a warm compress. We do not massage the site. Why do we not massage the site? Pause this, answer the question, and turn it back on. Hopefully you were able to answer this immediately. We do not massage the site because it is a blood clot. And what do we not want that blood clot doing? We don't want it traveling. So you would not massage the site. And we know this, that we rotate IV sites every 96 hours. Or per your facility policy if it's something else. But right now best practice states every 96 hours. And this will help prevent this complication and many of the others from occurring. Alright, nerve injury is just what it says. It's injury to the nerve that occurs during the insertion that's due to being too close to a nerve, the vein being too close to the nerve. Can be caused by the close proximity and you hit a nerve during the insertion, or it actually can be caused from nerve compression, from infiltration or extravasation. We have all that extra fluid in there and it can compress the nerve. So what is the patient going to feel? They're going to have an immediate sharp pain. If you had a nerve, if you've ever had nerve pain, you know what I'm talking about. It can shoot, radiating pain that shoots up the arm or up the extremity. Pain, tingling in their hand, their fingertips. You can see pallor. Okay, it can turn a pale color and actually can restrict movement in severe cases. We definitely want to stop insertion immediately. We will let the physician know. We want our arm to be at the level of the heart, and this actually promotes arterial flow, and that will help if we have nerve damage. And apply pressure to the site to prevent a hematoma from occurring when we remove it. And of course we always apply pressure to the site whenever we remove an IV. Nursing considerations: you want to avoid using the lateral surface of the wrist and the antecubital or AC spot. This has a higher risk of this. Avoid probing whenever you're starting an IV. Don't be digging or sticking. And as you guys already know, only 2 attempts. Okay, local infection. Here in just a little bit I'm going to put a slide in that compares local versus systemic infection, but local infection is infection at the site where the IV is actually in, and it can lead to a systemic infection. If we get an infection where the IV is inserted, it can lead to sepsis if we are not careful. What causes it? Not washing our hands, inadequate skin prep, and not using a septic technique whenever we're inserting the IV, and of course poor maintenance of the IV over time. What are we going to see? We're going to see redness, swelling, pus, drainage. It's going to be warm, possibly have an odor, and this is all at the site or locally. We would want to DC the catheter, culture the site. We're going to have an order for that. We would apply a sterile dressing over it. If we have to administer antibiotics, we would. Again, we're going to have an order for that. And then we would let our doc know if we suspected infection at any time. As the nurse, we want to make sure that we are doing hand hygiene, that we are using aseptic technique, that we are cleansing properly. We know that we now clip hair instead of shave it. Okay, it has better outcomes and less risk of infection. We want to make sure that our IV sites and our IV tubing are changed per policy and procedure, and we will we know that our sites are to be rotated 96 hours, and depending on the tubing, IV piggybacks are every 24 hours, and continuous flow is also every 96 hours for tubing. Making sure that we assess our site continuously and properly. Venous spasm, this is just a sudden involuntary contraction of the vein. It results in temporary blood flow, stopping of the blood flow through the vessel. What can cause it? Things that can cause it are if we're infusing something too cold or something too irritating. If we infuse it too fast, we may have vein spasm. Also, if your solution is too thick. So all of those things can cause a venous spasm. If your patient's really anxious, that can also add to it. What are they going to feel? They're going to have a cramping or possibly sharp pain near the IV site, and it can travel up the extremity. We would want to apply warm compresses, and which will decrease the flow rate until the spasm subsides. Okay, so if we're on a pump, we would want to decrease our rate, and if it's not relieved, then we would have to remove the IV and start it in another site. We want to make sure as the nurse that we have adequate dilution to our medications, that they're not highly concentrated, that we are administering at the rate that they are prescribed. And a lot of times if we need to, we can use a warmer to warm fluids. For example, we do that with blood administration sometimes to help prevent reactions. And also our IV fluids, don't infuse them when they're really cold. Let them get room temperature before we infuse them. Okay, all of the complications that I have talked to you so far are considered local complications. All right, the next ones that I'm going to talk to you about are systemic, and then I actually will compare systemic versus local infection on one of your slides as well. But I want you to know that the ones we previously talked about are local. The ones we're fixing to talk about now are systemic. I have also posted a chart online for you to look at. It kind of just breaks it down and makes it a little bit easier, each complication and everything that's going on with it. But you need to know the difference between local and systemic and the different complications that occur and why they are occurring and what we're going to do about it. Another complication that we know can occur, and we've talked about this previously, is fluid overload. Fluid overload is a condition that's caused when you have too large of a volume that infuses into your circulatory system. That's what's occurring with fluid overload. We have the possibility of what we call flash pulmonary edema. And flash pulmonary edema is whenever the fluid is infused too fast, and it can increase venous pressure with the possibility of cardiac dilation, and then subsequently we would have pulmonary edema. It just comes on extremely quickly. The pulmonary edema does, and that's why we call it flash pulmonary edema. Signs and symptoms that you may see: you would see engorged neck veins, hypertension, shortness of breath, or dyspnea. As the nursing considerations you want to think about, you would want to slow the rate of infusion. So if we know that we're overloading our patient, maybe we just need to decrease the rate that's the IV is going in. We would want to let the doctor know. Monitor vital signs and the rate of the fluids, and make sure that we're checking on it frequently if we're concerned about fluid overload. Air embolus, that's just when we have air in our circulatory system. It can be caused by a break in the IV system above the heart level, which allows air into the system as a bolus. So therefore we have an air embolus or an air bolus in our system. Signs and symptoms that you may see: obviously respiratory distress, tachycardia or increased heart rate, cyanosis, decreased blood pressure, change in the level of consciousness. When you're thinking about these things, and we will review some of these in class as well, but I don't want you to just memorize this sign and symptoms goes with this complication. Understand why. If you pushed air into a patient's circulatory system and it went to their heart, okay, think about the anatomy and how the air would travel and what would occur. Why would your patient have respiratory distress? Why would your patient have tachycardia? Why do you see decreased blood pressure? Don't just memorize, but understand why you are seeing these symptoms with these complications. Nursing considerations. Obviously, you want to stop any more air from entering if at all possible. So pinch off the catheter to prevent entry from the air. We want to place the patient on the left side. Now think about this. If we have entered air into our circulatory system, where does our circulatory system end up at? The heart, right? So why would it be important for a patient who we believe we just air embolised to lay on their left side? Pause this, think about it, and come back. I'm hoping that your critical thinking has kicked in and that you look at it in this aspect. We want to place them on their left side because what happens to air? Air rises, right? So if you put me on my left side and I have an air bubble on the right side of my heart, then hopefully it would rise to the right side and would not try to push through into the right ventricle. So hopefully I can keep the air trapped there until I can get enough oxygen, which is another thing that you want to do is administer oxygen. Until I can get enough oxygen, think about a hyperbaric chamber, into my body, and so that my body can reabsorb and correct that bubble before it tries to go from the atrium to the ventricle, blocks off that valve so that no blood can get through, right? So make sure that you place them on the left and hopefully understand why you place them on their left. No, not hopefully. You do understand why we place them on their left and that it needs to be done immediately. If you've just given an IV push and you feel like you've embolished your patient, you need to put them on their left side immediately. I've already told you that we need to administer oxygen. Obviously, you would call for immediate assistance, making sure you're monitoring vital signs, pulse ox, and just your patient in general. This usually occurs with central lines. That's when it's more often going to happen to you than with any other type of line, and that's due to the size of the vessel that it's in, the size of the line, and the techniques that we use. Okay, infection. Local versus systemic. Local is an infection at the site of entry, where the IV is actually in. Systemic is when it's in the bloodstream. With a local infection, you're going to see redness, warmth, pus, odor, drainage. With systemic infection, and when I say systemic, I'm talking septic here, you have microorganisms that's invaded your bloodstream through that IV site. It can be caused by poor insertion technique. It could be caused by multi-lumen catheters, long-term catheter insertion. We know that the longer it's in, the higher risk we have for infection. And frequent dressing changes. We always do our dressing changes according to policy. So the more often we're taking those dressings off and reapplying them, the better chance we have of entering microorganisms into the system. With systemic, signs and symptoms, redness, tenderness, you're going to see fever when it becomes systemic, malaise, you're going to see vital sign changes, tachycardia, hypotension. You want to make sure as the nurse that we are assessing the catheter site daily. We would let the physician know immediately if there were any signs of infection. If there was drainage, we would want to culture it. Of course, we'd have to talk to the doctor to get an order for that. And we want to use aseptic technique when we start infusions. That's why it's so important that we use aseptic when we're starting our IVs and when we are working with them. Okay, speed shock. I've mentioned speed shock to you before. It's the body's reaction to the substance that's injected into our system too fast or too rapidly. Usually with an IV push is whenever you see this. Rapid infusion can allow the concentration of the medication to reach toxic levels, which would flood to our organs, which are rich in blood. Usually our heart and brain is what we're talking about. And as a result, we'll see syncope, shock, and even cardiac arrest. So speed shock is a very serious thing. Again, it's important that you administer the drug as per ordered and as per your drug book states that it should be administered. Signs and symptoms you would see with speed shock. They would have a pounding headache, fainting, rapid pulse, apprehension, chills, back pain, shortness of breath. Make sure that you're not memorizing these symptoms, but understanding why these symptoms would occur. If you're shoving in a drug too fast, why would they have a headache? Why would they have apprehension? Okay, so think about that as you're thinking about these complications. And again, we'll talk about these things in class, but it's important that you're just not memorizing these, you're understanding why they're occurring to your patient. You would obviously want to DC the infusion or the push immediately. Say you still have some in the syringe, you would want to stop it. Sometimes it's already in and you can't stop it because there's no takebacks with pushes. Notify your doctor, making sure you're monitoring your vital signs. Make sure that you use correct IV tubing and that you're monitoring your IV flow rate, because those can play a part in speed shock, because it doesn't necessarily have to be an IV push. That's just where we most commonly see it. Making sure that we're checking our rate frequently for accuracy. And if something was hanging to a gravity, that Johnny the grandson didn't reach over and just open up that clamp for you so that it's just running in too fast. Okay, whenever we're talking about choosing a location, when we choose a peripheral site, we always want to assess for the safest, most appropriate location for what we're doing or what we need the IV for. When we select the site, we want to consider the accessibility of the vein, cephalic, accessories, cephalic, metacarpal, basilic. What vein do we want to use here? How easy is it to get to it? Only use the AC if absolutely necessary, because the AC, that site, is usually used for trauma and emergent situations. It is very easily dislodged. So you want to only use that if absolutely necessary. Do not use the veins in the legs unless it's absolutely necessary, or you have an order, because you have a high risk of emboli with the veins in the leg. The condition of the vein. Make sure that there's no scarring or fragile thin-walled veins if you can help from going into those. The type of fluids that's being infused. We want to look and see. Is it hypertonic? Should it be in a larger vein if possible, to decrease the irritation that is occurring? We've talked about potassium in the past and how irritating it is to the vein, and we wouldn't want to give that in a concentrated form through a peripheral site. So we want to always consider the medication that we're administering, and also the duration of the infusion. Am I just going to give this over 30 minutes, or is this going to be going for the next 3 days? So that has a lot to do with how we choose the site that we want to start our IV in. Okay, drug incompatibilities. They are not always obvious to the naked eye. They are classified in 3 different ways: physical, chemical, and therapeutic. Physical is a change that is physically observed, such as precipitate. Okay, the most common form is precipitate. It could be change in color, it could be haziness, and what happens is that we administer a medication through a main line, and it actually crystallizes or hardens inside that line. So you can imagine the complications if that were to get into your patient's body. The presence of calcium in a drug increases the risk of precipitation, so you want to watch that. LR, or lactated ringers, contains calcium, so you monitor if you're infusing something through LR. Drugs that have sodium bicarbonate also have a possibility of it, and the big thing is that physical means we can actually see it occurring. Chemical, it actually involves the degradation of the drug. It occurs at the molecular structure. It may or may not be observed. Okay, so you may or may not be able to see it. It is the most common reaction, and it's actually between acidic and alkaline drugs, and it usually affects the pH. You have an unstable pH, and that's what is occurring with this. Then the last one is therapeutic, and that's when a reaction occurs in the patient as a result of 2 or more drugs being given concurrently. It can be an increased or decreased therapeutic response. So either or can occur. The drugs that are given, this is actually occurs in the body, so it's not in the line itself. Although you do need to know that if you are giving, if they have a main line, they have 2 antibiotics. One is hung, it's done, we go get the other one, we start to hang it. Even though that antibiotic, that first one, is done and through that line, it still could have some properties still left in that line. So if you're infusing a second antibiotic as a piggyback, there could be incompatibilities. Even though they're both compatible with the main line, doesn't mean they're compatible with each other. So you do want to watch that. But when we're talking therapeutic, we're talking about a reaction that actually occurs in the body. So if you're giving 2 drugs through 2 different ports, it's not through the same line, and you're having a reaction from them both going in at the same time. It's best to make sure that you stagger administration times, especially with like antibiotics, so that that does not occur, and you will see signs and symptoms in your patient that are either toxicity or that they are not receiving the drug, so you're not getting the response that you actually want. And the big thing that you need to know is never, ever, ever mix medications if you are not absolutely positive that they are compatible. And that's the end of your complication